mean, I think the other question is about, and this is something we've in the past spent a lot of time on. This time, let's try and fit it in here, and that is, how do you guys, at least in a newly diagnosed setting, how are you using MRD to drive decisions early on? So I'm not talking about at 1 year. I'm talking early on in the induction setting, or perhaps around the time of transplant.
So I actually have a lot of savvy patients that come to me and say, I've heard I don't need a transplant anymore based on the IFM data, right? And so they want MRD done. And so I actually do it for some of my patients. And I think after the Forte trial, I'll probably have a little bit more data to share with them now. But if my patient really just does not want a transplant, and I'm a transplanter, right? Before, that's what I was born as. And if I can't convince them, we'll do MRD after 4 to 6 cycles. If they've had a CR, it looks like they're at a CR. If they're negative, we use it. This is not, validated or anything, but then we'll save their cells if we can, and then just go on with a salvage transplant at relapse. But that's not very many patients. Most patients agree to do it. Now, I think with the Forte data, if I do have ISS stage 1 patients who don't want transplant, I think, and since we do KRD, I think it'd be okay potentially, right? Yes, there's still better MRD when they did the transplant, but they didn't have the early relapse like the higher risk patients did. So if we're looking at PFS, and that's what my patients are looking at, then I can use that data to say, okay, maybe those are the patients that, but high risk, I would still really try to say to do transplant.
Okay. You all? I know Tom's a big proponent of MRD at every cycle.
Well, we do a lot of MRD.
Just leave the needle in there?
Yeah. The early assessment time point, it's really difficult because there's not a lot of data on what to do at the early assessment. And the assessments are typically done post-transplant or even 18 months after transplant, so it's kind of post-hoc. Joaquin Martinez-Lopez has an abstract here based on real-world data from UCSF. And he's going to present it tomorrow. Jeff will present it. And really, the value of doing MRD, in my mind, is this sequential monitoring of MRD. And it's when sequentially you see continued MRD negativity. Those are the patients that actually do quite well. I will say that we did not intend to do any treatment decisions based on MRD. And so we didn't make any early treatment decisions based on MRD, but we have made later transplant decisions based on MRD. Somebody's having side effects and they're on maintenance and they're MRD negative for 2. The patients want off, and we allow that to happen.
Yeah. I mean, I will say we've sort of pulled our data on RVD induction, transplant, and maintenance, continuous len maintenance in about 1,000 patients. And the median PFS in that group is close to 76 months, between 70 and 76 months. I mean, that's pretty good. And so I would suspect the reason we're not seeing a difference in Forte is because the follow-up's only 2 years.
Exactly.
And so for the standard risk group, it's going to take much longer for those curves to separate. But if you'll remember back when Antonio presented data years ago on CR, transplant versus no transplant, the response rate was identical, CR rate was the same, but the transplant group had a better PFS. So I think, to me, MRD is a nice CR that does have prognostic implications, but I'm still a little hesitant to use it to make a decision early.
Same here. The only situation where it would make sense is the high-risk patients. I don't think the high-risk patients, you raised a very good point about the threshold, 10 to the minus 5 versus 10 to the minus 6. What's the real MRD negativity threshold? I think 10 to the minus 6 is even more important for the high-risk patients. 10 to the minus 5 doesn't mean anything for those patients. And if you have an MRD negative patient that turns positive, it may not be as a big deal for the standard risk patients, but it would make us think differently for the high-risk patients and probably change what we're doing with them.